Well, welcome back, everybody. I'm Elena Rios. Happy to be chairman of the board of the Better Medicare Alliance, and I want to say that this is a fantastic event. I think every year it gets better, and I want to thank Mary Beth and everybody that organized the meeting. I'm really happy to be here. I'm actually president of the National Hispanic Health Foundation, and let me say I'm very proud of the fact that so many more Hispanics join Medicare Advantage than Medicare fee-for-service. And I think they see the light and know that coordinated care is important, especially in our family-oriented Latino community, where people want to have child care and transportation and everything taken care of all at one time. And that's one of the important things of Medicare Advantage. And I also want to just have each person here introduce themselves. But I do want to say that, as Dr. Oz said, we now have the privilege of listening to the innovators from our country on Medicare Advantage, the private sector. And I think that it's very important to realize how fast things move in the private sector compared to the public sector. And I was at HHS many, many years ago and can attest to that. But we do need public-private partnerships, and I think Medicare Advantage is a great example of that. So let me have Dr. Decker, if you introduce yourself.
Yeah, thank you, Dr. Rios. Dr. Wyatt Decker, an emergency medicine physician who serves as chief physician at UnitedHealth Group, focused on value-based care and innovation. Mm-hmm. And I would just submit two quick sort of thoughts. One is, I think in health policy, we find ourselves today having the wrong conversation. The conversation too often is defending Medicare Advantage, which is a comprehensive solution, as we've been hearing about today, as if the fee-for-service system is some sort of a gold standard, which, as we all know, is far from the truth. So to the extent that all of you as leaders, and I know we have at least a few members of the media in here, we gotta wake up. The United States has in some ways, more of a sick care system that does a pretty good job when you're in crisis and you need that acute hospital intervention for an acute MI, major trauma. But we definitely don't have a healthcare system that focuses on keeping us healthy and well. And probably the best scaled example of something close to that, not perfect, but close to that, that focuses on getting upstream of chronic diseases is Medicare Advantage. So I look forward to the conversation today. I think we can continue to drive this. Let's focus on keeping people in our country healthy and well in a comprehensive, affordable fashion.
Yeah. Okay. And next, Heidi.
Good afternoon. I'm Dr. Heidi Schwarzwald. I'm our Chief Medical Officer for Signify Health, which is part of CVS. Dr. Decker, you said that beautifully, but my career has been spent either seeing patients who are covered by government programs, Medicare or Medicaid, or working within the health system. And so I'm very excited to be here today. And you said talk about how do we make it a program for health.
Right.
Hi, I'm Dan Lowenstein. I'm Senior Vice President of Government Affairs for Visiting Nurse Service of New York, VNS Health. We're the largest home health agency in New York. We're also a sponsor of Medicare Advantage plans, including dual special needs plans. And I'm looking forward to talking about how care in the home is critical to what we're doing here.
Mike Cheek with the Special Needs Plan Alliance. I am not a physician, so if I say anything medical, don't follow it. We represent all of the special needs plan types, I-SNPs, C-SNPs, and D-SNPs. We represent 85% of all special needs plans in the country, and they deliver coverage to about 5.5 million of the 7 million enrollees in special needs plans. Pleased to be here.
Great. Okay, so I have a first question for Dr. Decker. Dr. Decker, how does the Medicare Advantage program allow you to address seniors' full range of needs?
Yeah. So I've had the pleasure of being in the audience today, and I think a lot of ground has already been covered in that space. So what would I say? First, let's just start with what we've been hearing today, which is that in a program like Medicare Advantage, you basically have a public-private partnership, often a three-way partnership: government, payer, and provider, which is great because then you actually have, instead of tons of friction, you begin to see these entities working together. So I love that. And I think the other thing that's super empowering about Medicare Advantage is, instead of saying, oh, should we pay a nurse practitioner, $45 to go into somebody's home once a year? We can just say, here's how it works. You're fully accountable for the care. You guys, between the care providers and the payers, why don't you just figure out how to get the best healthcare outcomes? And whether you want to invest in social determinants programs or AI algorithms to help nudge people, or more nurses to go into people's homes, it's your call. Your call. But it should be data-driven, and it increasingly is. And I think two things that I want to make sure everyone leaves this conference crystal clear on is that there's a strong and growing body of evidence that Medicare Advantage, particularly when we have value-based focused care providers, delivers better outcomes than fee-for-service. Like that should no longer be a debate. We see, and not just us, but in the providers, whether it's Optum Health, you heard earlier from ChenMed, who I have next to me, Signify. So when you think of the provider community that's engaged in this space, we see between 20% fewer acute hospitalizations, which is all of you know is where the costs are. But when you look at people with multiple chronic diseases, that can go as high as 40% fewer acute hospitalizations in this population. Then the other debate that unfortunately is still being carried on is, oh, but Medicare Advantage is more expensive. Well, first of all, it isn't, okay? That's the take-home message. Medicare Advantage for the U.S. taxpayer is debatable whether it's at parity or costs less as a comprehensive program. And on top of that, it costs, and you hear pretty much similar ballpark numbers for the senior or the dual special needs person, we're talking $2,300, $2,500 on average, and an out-of-pocket maximum, and you're not coordinating Medicare Part A, Medicare Part B, and your drug benefits through Part D, in some kind of a bureaucratic nightmare that we somehow expect seniors to effectively navigate. So it's comprehensive, it moves us upstream, and it focuses on keeping people healthy and well, which is I talked about earlier. So the last comment is care in the home, and we'll get into this. But this is the new frontier, I would say, especially for the vulnerable and people with multiple chronic diseases. We need to get to them in their homes and stop hoping they'll come to the doctor's office, at least for those who struggle to do so.
Dr. Decker, I couldn't agree with you more. I think the individuals don't understand the systemic changes and the decrease in costs overall. If people are not hospitalized, you're going to save millions.
That's right.
Billions.
And you get happier people. I don't know about you, but how many of you want to be in the ER? I'm an ER doc. How many of you want to be in the ER? How many of you have parents or grandparents that want to be in the ER for 6 hours, seeing what happens to them? It's super scary, it's super inconvenient, and it happens to be super expensive.
So Heidi, I want to ask you about risk assessments. And they're often the first step in connecting beneficiaries to needed services. Can you share how your organization and the CVS Health and Aetna also uses the risk assessments to identify risks early and to support coordinated ongoing care?
Thank you so much. Absolutely. So Signify Health, which is part of CVS Health, does in-home health assessments, and I know that many of your organizations do the same thing. The first thing I'd love to level set is the person that we're sending into the home generally is a nurse practitioner or a PA or even sometimes an MD. So they are at the same level as the physician that you might see or the clinician you might see in the office. And the assessment is a full assessment. It's up to 40 minutes sometimes. And I think about when people come into my office, we definitely are not scheduled to spend that much time with an individual patient, whether you want to or not. That's not how the schedule is set up. So it's that chance to spend more time, get that comprehensive look at everything that's going on. I go in and do these assessments myself on a regular basis, and last time I went in, one gentleman admitted he hadn't been into the doctor in 6 years. Well, this is a great opportunity for us to come to him and provide that access and be able to find out kind of what's going on. All that data then goes back to their primary care provider, because we are not the primary care provider, but we know that they are oftentimes overwhelmed and overstressed. And it goes back to the Medicare Advantage plan as well, so that that care can be coordinated from there. We know that when we're able to do diabetic retinopathy screenings in the home, 14% of the time we find abnormals, right, which haven't otherwise been found, and we're able to coordinate that. Over 100,000 times this year, we had people tell us they either had food insecurity or transportation issues or other financial issues, and we're able to connect them back in to get that care. Or sometimes, we sometimes see up to 10 to 12% of the people don't have a PCP. And so then we're helping connect them back in to get a PCP. All of those items really help connect the care completely. They may have diseases the health plan doesn't know about because the health plan's relying on claims.
Yeah. My mother was a nurse and home health care case manager for a very large FQHC. And she often talked about the loneliness of our seniors, especially women, living alone. And so I think the home health assessments is also good for the mental health of our patients.
And there's kind of a misunderstanding out there that nurse practitioners who are board certified, as you said, and they're practicing at the top of their license, that they're somehow just going in and trying to grab diagnosis for coding purposes. And it's anyone who is in this space and has questions about it should actually do a ride along, which I've done many times for myself. It's quite remarkable to sit with a nurse practitioner, mostly is our program, but the House Calls program, and see the interaction and how deeply meaningful it is and beneficial from both a social connection, but also a healthcare outcomes perspective. They pull out the meds, you're looking at them all on the counter, looking for fall risks, assessing mental health concerns, social determinants, et cetera. So it's just much more comprehensive, and unfortunately sometimes gets couched as kind of this kind of unseemly grab of diagnostic codes, and that's just wrong. That's just not what's going on. I mean, there's a component of it which we can get into, which is valuable, but there's so much more.
No, I agree. I'm sorry. So when I was speaking with Kathy earlier, one of the Medicare beneficiaries who spoke earlier today, I asked her if she'd had a home health assessment, and she had. I don't know which company, but she had one. And she was saying her favorite part about it was actually that we were doing early dementia screening. And so I asked her if they had her do the clock test. She said absolutely. And she relayed to me that very frequently other people in her social circle are not getting this. They're not getting, diagnosis of early dementia, or it's not early anymore, it's later. And then she's helping them navigate the system to get the services they need, instead of when we come in and are able to identify that. If you go to the doctor again for 10 or 15 minutes, you can probably fake it. I know my dad does and get through it, right? But when I'm in your home for 45 minutes and I'm seeing that the dishes aren't quite done and the garden that used to be perfect is not perfect anymore, you start to pick up on some of those early clues.
So let me ask Mike. I know, Mike, you have to leave early, right?
I was going to piggyback on what others were saying. Special needs plans are unique in being required to have a model of care that drives all of the operations of the plan. It has to be tailored to the population. The care coordination model has to be tailored to them, the provider network, and the quality metrics. And part of the care coordination piece is how the HRA is designed to feed into care coordination, and the information for that is used to drive the individual plan of care. The in-home piece to it, as Wyatt and Heidi were discussing, is critical because you see what the individual needs in their home, and this is a sad but very true fact, is that when the in-home visit occurs, or when an elder that lives in the community's transportation service provider arrives, that may be the only person they see for 2 weeks, 3 weeks if they're homebound. So being able to assess that individual for depression, which we know leads to cognitive decline. See, I'm wandering over into medical. I warned you about this. Leads to cognitive decline is important to understand as part of the in-home work.
So Dan, continuing on the issue of in-home assessments, in terms of what you think the role is, in addition to what's already been said, but what is the role of this assessments and the services and how they play in reaching seniors who might otherwise fall through the cracks, as we've heard, and they're isolated? And how do you improve outcomes for your members?
Sure. So I'm going to take it in a slightly different direction. As a home health agency, I want to talk about home health care. This is the care that usually comes to a senior after they are discharged from the hospital. Not always, but it's referred by a physician for somebody who needs care in the home for a period of time to recover, to rehabilitate. I'd also like to say, not only are we the largest home health agency in the state, we're actually the oldest in the country, I think, or one of the oldest. Over 130 years old, and actually, care in the home is actually not new. We had nurses going rooftop to rooftop on the Lower East Side because it was to avoid the muck of the streets, going down fire escapes into people's homes to give them, to provide health care where they didn't have access to hospitals. Either they were not allowed to go to hospitals, they couldn't afford it, and this is how they got their care. And this is how they learned also, this is the health education, helping people understand what is, how to take care of themselves is a critical part of what we do.
And how do they get between buildings?
Sorry?
How do they get between buildings? Jump?
Oh, this is the Lower East Side.
Very close together.
Yeah, on a block, and then they have to go down to the next block. Yes.
Yeah.
So
Superman.
So, but it's evolved. The mission is the same. The methods have changed, and we do assessments too. They're called OASIS assessments. And home health does assessments whenever after when the person is home at the start of care. This informs the care plan. They do them every 60 days for the recertification, and if the patient has gone into the hospital or nursing home and comes back. So we are getting this information on a regular basis, and have been doing this for, I forget when it was started, it was at least 20, 30 years ago. And actually this year is the first year that this is required of home health agencies for all payers, not just fee-for-service, but for all payers. We've been doing it for all payers for a while. And I will say that, and this is just a shout out to Medicare Advantage plans, we have very strong relationships with our plans. We are in capitated, or they're called episodic payment arrangements with most of them that are tied with value tied to key quality measures, including readmissions. These OASIS assessments are key to that, and I think that how this works in the HRA conversation is an interesting point we might want to explore.
So let's switch to some policy issues here. And Mike, you're going to tell us about the No-Up Code Act and what's the ongoing discussion about this legislation. What's your organization's view of the legislation? Any concerns, any ideas you hope to bring to the table?
Sure. I think in general, the No-Up Code Act has a long way to go before it's up in terms of being ready to go anywhere. The restrictions on HRA in-home and some of the limitations on the diagnoses that could be captured are highly problematic, particularly for special needs plans and the populations we serve. The other piece relative to in-home HRA is that legislation isn't needed to do what has been contemplated. CMS can do this now by adding 2 digits to procedure code for in-home to identify whether or not it's evaluative, whether it's whether it's a treatment, whether it's an annual wellness visit, whether it's by a special needs plan or a traditional Medicare Advantage plan. There's no legislative needed for that. So that sort of understanding from CMS technical technical support on what's needed in legislation versus what CMS could just do, ideally in collaboration with us to make sure it's working the way it should, as Dr. Oz noted, in terms of being creative and innovative and efficient in our work, would be the next positive step with no upcode. It does appear that they have slowed down considerably on no upcode in terms of the work. So we look forward, and I'm leaving to go to the Hill after this to discuss this with 2 staffers, that they pump the brakes further and have a dialogue with us more broadly around what CMS can do in collaboration with us now versus what's required in statute.
Unfortunately, I would submit that it's a misnomer, and among other things, it eliminates the ability to go into people's homes and capture important diagnoses. You talked about diabetic retinopathy. I mean, that's just a list of literally hundreds of potential diagnoses that are meaningful to capture. And interesting now that we have an increased focus at HHS on a nation of chronic diseases. So let's not wait until you're blind. Why does the United States have twice the amputation rate for diabetics that the rest of the developed world has? Because we don't get upstream, because we're not going into homes enough to say, hey, that little sore on your foot might lead into something much more problematic a year from now. So here we're going to teach you how to take care of it. So why would we? To me, it's a step backwards. It would be eliminating the incredible progress that has been made and getting into seniors and duals homes. What I would also submit is sometimes when you oppose legislation, then you begin to sound like a Luddite, like, oh, everything's perfect, nothing should change. And that's also far from the case. And I think BMA has been very thoughtful about your positions, Mary Beth, here, because we all agree, or I think we almost all of us would agree, that there are opportunities to improve home visits, right? So, and one of the most critical is, let's make sure that if a nurse or a physician is in somebody's home, that those findings integrate with that primary care physician's or NP's office practice, right? And so I think mandating that there's good communication, which is something that is a best practice. Signify does this today. We do it today at our house calls program, but it isn't uniform. I think that's an example. And let's hold those who do in-home visits accountable for outcomes and metrics, and whether it's self-audit or auditing, let's do it. Like, let's say, here's what we believe these visits should entail, and we're going to hold those who practice them accountable for those metrics. Does that make sense?
It makes complete sense, and I would just, I would really just emphasize what you're talking about is the in-home health assessment is part of the overall care team, and so holding everybody accountable that information is shared and acted upon makes complete sense. But that doesn't mean you remove that crucial part of the care team instead of enhancing its ability to work across everyone.
Yeah.
So you already mentioned, Dr. Decker, the administration's focus on chronic disease, and actually it's focused on prevention also. And so I don't know if anyone wants to answer about the Make America Healthy agenda and the importance of wellness, prevention, social determinants of health. But where do you see your organizations helping to lead the way and see this momentum being built in healthcare to kind of switch gears a little bit from a medical model, to a more, I'll just say, a more public health model?
So, a few statistics. Home health, when somebody is referred to home health and doesn't get it, which happens about half the time, sometimes 70 or 80% of the time, depending on the community, they are referred to the home health in a hospital, but nobody's available. Nobody's available. They go home, they don't get it, they end up back in the hospital or they die. All right? And those are real things. In fact, 41% of people in that category, it's basically you're 41% more likely to die if you were referred to home health and didn't get it than if you did, and 34% more likely to be readmitted. Okay? And it also costs the costs are much higher, about $2,400 higher in total cost of care over those 90 days post-discharge. So the value is there. The investment is not. This is I will say this for all payers, but Medicare fee-for-service has cut home health rates by about 13% since 2020. They have a 9% cut on the block for next year. The results are what you would expect. There's been a 25% decrease in home health utilization since 2018. 1,300 agencies have shut their doors, and this is much worse in rural and in urban inner-city urban communities. So the value is there. The investment, and this affects Medicare Advantage plans too, because the nurse is not differentiating between a fee-for-service or a Medicare Advantage plan. The workforce is either there or it's not. And I think it's going to take investment and collaboration across all payers to kind of recognize the value there and to avoid the sick care system that we're trying to.
You mentioned the workforce, and as we have a less workforce in certain areas like rural America, decreasing clinics, decreasing hospitals, how do you think AI can help with being more efficient, not taking the place of human beings, but Project Echo, for example, is a project for
we're leaning way into
rural
AI,
and other,
including in the assessments. They're very helpful for helping to capture things during the conversation that you wouldn't have caught, that a nurse may not have it. Or I'm sure Signify has seen some of this too. But yes, again, it's not going to replace, just like any technology is not going to replace that. But it is a supplement, a very important supplement to the work that we're doing.
Yeah, I don't know if anyone wants to talk about this. MAHA initiative also is looking at wearables, and I know now there's lots of transfer of data from scales, for example, for obesity and heart disease and heart failure.
I'll jump in on wearables because I've got one on. I think it's super interesting. I think there's a need for those who are building and promoting wearables for clinical and health economic outcomes data, right? So if you think your gadget is going to improve someone's health outcomes, it needs to be proven. It doesn't need to be proven in 5 million people. It can be proven in 1,500 got the intervention, the scale with a digital feed onto an app and into a doctor's office versus not. And some are validated, but that's probably a lot of us up here on the stage, we get approached regularly by let's put all your seniors on this gadget or that gadget and put this in their home or that in their home. Some of them are quite interesting sort of technically, but it has to actually improve clinical outcomes. The other thing I'd say is it can't overwhelm the user, the senior, right, or the dual, and it can't, the person. And it also, think about the other end of that. As a doc, be careful of white noise. You just get all these readings coming in. How are they screened? And then how do you not miss something that is clinically significant? So I think wearables are in early days. I think there'll be a big filtering out, but I do think ultimately it's going to be a nice step forward in clinical management.
Yeah. So we're just about ready to wrap up here. Can each of you just tell the audience a future initiative that you're working on right now?
I think something that it's an increasing trend for us. It has been in I-SNP, institutional special needs plans, but we're seeing it in other places as well. And those are provider-led special needs plans that are owned and operated by providers. Dan noted that they have D-SNPs, and that creates a real opportunity for streamlining provider and plan communications, information exchange, and relationship relationships between the staff that are working in the provider in the skilled nursing facility, in the adult group home setting for community-based DSNP enrollee, where the provider may own and operate in whole or in part a DSNP. So those types of relationships are things that we're really exploring, and quite a substantial number of our new members are small SNPs owned by providers, and looking at the ways that they can connect clinical information through information technology that's more seamless.
Great.
I want to just pick up on that. What Mike is saying is all about integrating Medicaid and Medicare, right? This is how can you get these two systems that generally don't talk to each other to serve essentially 30% of the population of both Medicare and Medicaid. I think maybe it's 15%, I don't know. But it's 30% of the cost, 15% of the population. That's what it is, of both. And there's a lot more we could do. And the DSNPs that Mike is mentioning are critical to ensuring that care is in the home, that the Medicaid and Medicare services are coordinated where they're generally not. They're not in fee-for-service. And I think we have a good, I think the administration is really looking at this and wants to take it seriously and is very open to new thinking on this. So.
Heidi?
Staying on the theme of integration, like we've talked about before, we know that after we go in to the home and we gather all this data and we're able to integrate it back in, but we're really beginning to think about how do we do that more instantaneously. So where can AI play a role? Where can better knowledge about the different supplemental benefits or different benefits that are available to a member are there, so that as we're doing our assessment in the home, sort of in the background, things are percolating and it's saying, guess what? Mrs. Jones, after the assessment I've done, it looks like you really need a grab bar in the bathroom, an easy example. How can I make it so that my nurse practitioner in the home can push a button and that grab bar comes out? So that's really what we're focused on for our next innovation, is making that connection faster.
Wow. Dr. Decker, last word.
I love the question. I feel like it's like being a kid in a candy shop, like eliminating prior auth, putting healthcare on your phone.
Yeah, but just one.
And so I only get one, and I would say it's really about healthcare for us at UnitedHealth Group. It's about healthcare 2.0. We believe that U.S. healthcare should be focused on keeping all of us in this room, our loved ones and our parents, healthy and well, and that we should be able to meet people on their terms. Some of them more wearables, more digital, some of it more personal touch with somebody coming into their home, and wrapping it together in a seamless fashion so that we remove all the super irritating friction points in all of our healthcare journeys.
So thank you all very much for enlightening us on Medicare Advantage from the innovator side of the world and our private sector. Thank you all very much for everything you do.
Thank you.